I believe prostitution should be legal. Okay, what the hell is he talking about?
Did not expect you to go there.
You didn't expect me to go there, but follow me along here, okay? Everybody is taking GLP-1. It's the same as the sex industry. Everybody's doing it, but nobody admits to doing it.
It's still like we don't want to talk about it.
Right. So the equivalency with the prostitution is this. It's like prostitution being legal. It's happening, but it's happening behind closed doors. I don't want to tell my doctor. They're overdosing. They're looking like Shar-Pei dogs. They're losing muscle mass. They're feeling terrible. Not because of the medication, but because they're not providing the ancillary care that goes along with the medication.
Welcome to the show, Doc. Man, I'm so excited to have you on today.
Oh, it's great to be here. I appreciate the opportunity, and hopefully, whether people agree or disagree with what we're about to say, hopefully we get people to think.
Yeah. Yes, seriously. So think and then action afterwards, right? Love it. Love it.
One of the big things about healthcare is that doctors expect compliance. Out of fear and trust, you're compliant with what they tell you. My job is a consent. I want to tell you the benefits, the risks, the alternatives, and then share the decision-making about your own health. Because it's not my health, it's your health.
Right. Yeah, I agree with that 100%. Well, let's get right into it, Doc.
Let's do it.
All right, Doc. So, for me, I'm extremely passionate about helping people with lasting weight loss strategies. I was an overweight, 300-pound 16-year-old myself, and I struggled for almost a decade. So, the whole thing, you do it yourself and you get inspired to help others. So for me, I get extremely excited with my work. I thought I would ask you a question first, if you don't mind me asking, both either in your professional or outside of your professional career. What gets you the most excited? Like every single day when you're thinking about your day to day, what is it that really drives your motives here?
Oh, it's very easy. There are two parts to this. The first one is the return of the investment of self-care. So it doesn't have to be anything big, but when I come back from walking my dog, if I've had my run, if I've had a little spiritual moment for myself in the morning, the self-affirmation that I'm able to give myself for those quirky little things that I do, that more so than anything gives me that emotional money in the bank. It's emotional buoyancy. So that's personal. It's unique to me. Nobody else knows about it. I don't care what anybody else thinks. It's quirky, but it gives me the ability to float through my day no matter how much noise comes at me. So that's a personal thing. And then there's nothing better and nothing more reinforcing than the transformative success of my patients. I don't know if you're the same, but I suffer tremendously from what I call imposter syndrome, which is how the hell can I be right if everybody else tells me I'm wrong? So nobody questions what I do more than me. And I'm very willing to be wrong, but every patient I see reaffirms to me that this maverick, crazy pathway that we're on, this crazy management style, is improving people where they've spent their whole life trying to do right and ending up going in the wrong direction because the information that we're working on was incorrect. Those are the two parts. There's self-affirmation and then affirmation for my own patients that allows me to reinforce that this pathway is not maverick, it's not wrong, it is correct.
That's awesome. That's awesome. How many more years do you think you'll be practicing for?
The math is easy. I'm going to drop at 100. I'm going to wake up dead one morning. Well, you can calculate that. I'm 27 years old right now. I like to think, but you can subtract that. I'm Benjamin Buttoning, that's why. But yeah, no,
there you go.
Which is a large part of what we do for a living is get people to be younger, even though they're chronologically older, biologically younger, despite chronologic aging. Death is not something I'm afraid of. I'm afraid of being sick. Death is my wife's problem. She's well taken care of. Got a great life insurance policy. What I don't want to do is I don't want to be a burden to people, and I don't want to die in pieces. And for the most part, metabolic health or metabolic illness is about progressively dying in little pieces. And that's not the way I want to go. I don't want to die of Alzheimer's. I don't want to die of cancer. If I go, it's going to be sudden. That's what I pray for.
Yeah, no kidding. How far do you think we're at from the medical society really finally incorporating metabolic health strategies into the curriculum for medical doctors? Are we closer noticeably yet, or Are they still just like, what's your opinion on that?
Well, I think it requires a complete overhaul at a policy and an infrastructural level in terms of what we deem to be healthy. The whole word about healthy is just so upside down. And to date, for the last certainly through my lifetime, but since the early tobacco era, it's been dominated by industry, who's defined health, not by healthcare that's defined health. Industry and religion have defined health more so than human biology. And I think returning back to a conceptual understanding of human biology and physiology as opposed to epidemiology. Physiology is the study of disease process or of health process. How does the body work? Epidemiology is looking at outcome metrics and saying, okay, this thing happens, here's a medication we can throw at it.
Right.
The body doesn't work that way. So at a policy level, you ask me how long, what's going to happen. I think a major shift has happened recently, and I'm not political at all, but we've been practicing, or I've been practicing, I know you have too, in the shadows for many years, fighting against an industry-driven agenda. And for the first time now, the door is being opened to those of us that are looking at this biologically. Are we going to make mistakes? Of course we are. Are we going to be right about everything? No, we're not. But we want to be on a trajectory where we're not afraid to explore and improve biologic health. You know, you mentioned before we came on air the GLP-1s. Well, we've known about incretins forever. We never knew what they did. Now suddenly there's this massive blowout because we've discovered it. You know, in 1964, when Randall wrote up his work about the Randall cycle, he didn't know what glucagon was. A couple of years later, we knew what glucagon was, radically changed our understanding of metabolism. So all of these little events are things that we need to be open to, but the door's been closed on that. And that's a problem. That's been a problem. So policy shift is going to change. And then slowly over time, that is going to infiltrate into our medical school curriculum. And really not just by ideology and understanding, but also by the weight of metabolic health being the single most dominant source of knowledge, because the majority of people are going to die and get sick because of metabolic ill health. But a policy shift at a government level is required, or at an advocacy level is required in our entire food system. But that includes, for example, who we subsidize. We're subsidizing Monsanto. We're subsidizing a plant-based agenda, which is fine. But now let's come back and start subsidizing some of the animal products, some of the poor ranchers that are struggling. Let's make raw milk in the state of Florida more legal than marijuana. I can buy marijuana anywhere I want to, but I can't buy raw milk unless it's for my dog. That's ludicrous.
Yeah. Yeah, no, it's so funny. We were talking about that, and then we'll get into my first question here on obesity. But I've got to add to that, when I think of GLP-1 medications, and so many patients, they're like enamored, and even doctors too, when I talk to them, the GLP-1s, and there's like 10, 15 different categories across the body that they target beyond just insulin resistance and inflammation, the neurodegenerative protection, addiction issues, non-alcoholic fatty liver disease, chronic kidney disease. But people speak of it as if there's some sort of magic behind how one compound could do so many things. And I'm always like, and I'm actually curious what you think, if you agree or have a different thought, but it's just because we finally have a medication for the first time ever that actually gets to more of a root cause part of physiology rather than just a particular symptom, right? All of our medications are chasing just a symptom. And this is like, no, this is like at the root cause, the origination of all these other metabolic issues. Is that kind of how you see it too?
Well, yeah, I would phrase it slightly differently in that all of the things you mentioned are the consequence of the disruption of the insulin-glucagon ratio. The human body is very homeostatic. What does that mean? There's an ebb and a flow. For every action, there's an equal and opposite reaction to be as healthy as you can be. And it's carefully rotational in almost a vibrational way. When you upset that vibration, that feedback vibration, you get into trouble. And currently, because of the way we eat and the food recommendations, the overwhelming driving force between the amount of carbohydrates in our diet and the frequency with which we eat, we are continuously driving everything in one direction, and the eye of the needle there is insulin resistance. And what the GLP-1s do specifically is they treat insulin resistance. So when you mentioned that, that is correct and that's absolutely true. However, all the endpoint diseases, whether it's obesity, diabetes, all the endpoint diseases, neurodegenerative disease, all of those things are the consequence, heavily influenced or directly or indirectly influenced by insulin resistance and by a disruption in the insulin-glucagon ratio or relationship. So as you begin to correct that, you reverse or restore that normal cyclical order. So the GLP-1s are just really reproducing a natural hormonal biology and forcing that to a certain extent. But the problem that we have, and bear with me here because I think this is such an important point, and I'm going to go a little maverick in terms of understanding this. Okay, so follow me along. I believe prostitution should be legal. Okay, what the hell is he talking about?
Did not expect you to go there.
Didn't expect me to go there, but follow me along here, okay? If you look at the internet, if you look at everybody's advertising, whether it's Tinder or Grindr or OnlyFans, everybody is selling sex, but it's illegal. It's not, if you make it illegal, it's not that it's not happening, but it's happening behind closed doors. And the problem is these men and women are not getting adequate protection. They're making it up as they go. They're not seeing doctors for fear of getting prosecuted. They're not out in the open, and they're being taken advantage of. So while it's happening and people are making money, it's happening in the most awful of ways. If you legalize it, now these men and women are able to seek adequate health care. They come under governmental and policing protection rather than becoming the animus of the police. And it's going to happen whether you like it or not. But now we're able to have it happen in a safe way for everybody. Everybody is taking GLP-1s. Okay, it's the same as the sex industry. Everybody's doing it, but nobody admits to doing it.
It's still like we don't want to talk about it.
Right. So the equivalency with the prostitution is this: if you allow people to access GLP-1 medications over the counter, no prescription needed, it would massively lower cost. It would take the pharma control out of the equation because the majority of my patients that I prescribe it for, the pharma and the insurance companies block them with prior authorization. They've said ridiculous. You've got to be 99% dead before they'll approve it. And yet the FDA has approved it for so many indications at a high scrutiny level, but the insurance companies don't cover it. If they do, you're paying $800, $1,200 a month for it. Yeah. Well, this medication costs less than $6 a month to produce. So if you made it over the counter, you allowed patients to access it fairly freely like they would aspirin. They're still going to, the same people are still going to take it, but now they can come to their doctor and say, look, I'm taking this medication. I want to take it. Please, could you help me to dose it correctly, to change my behavior patterns so that it works well, so that it's like prostitution being legal. It's happening, but it's happening behind closed doors. I don't want to tell my doctor. They're overdosing. They're looking like Shar-Pei dogs. They're losing muscle mass. They're feeling terrible, not because of the medication, but because they're not providing the ancillary care that goes along with the medication. And if you say, oh, that's radical, how can you have it? The medication is available over the counter in Mexico. You don't need a prescription in Mexico. It's dirt cheap, and Mexico has seen an improvement in their obesity, an improvement in their diabetes, not this massive disruption of what's going on. When we legalized marijuana, I mean, yes, Colorado's under this big cloud but nothing bad has happened.
This is where it started, by the way.
Right, of course, I understand. That's what I'm saying. But the point is that by legalizing marijuana, we haven't made things worse. We've made things better. Those that are using it are now using it under control. They're not afraid to go and get taken care of. They're driving more responsibly. Again, there's this response level that we've had as a society. So that is my take on it, but it's not going away. It's not going away. Let us bring it out of the shadows, allow people to access it economically well because it's got enormous benefits, as you and I know, and let's stop buying into the profit sector and make this a metabolically healthy medication. There's my 2 cents worth.
No, I love it. I love it. And like you said, with the people that we have and the changes that are happening with people being appointed into the Senate, it's extremely exciting. Let's lateral into obesity, because what a complex term to try to define, right? And, me and you know how outdated the calories whole, explanation of obesity, yet it still seems to persist. And when you dig into it and you actually look at the literature that's available, trying to spruce this out and figure out what is actually the driver, you got these highest randomized control metabolic ward studies that tell you when calories are accounted for, it didn't matter. Now, I can pick those apart, but this kind of relates to the obesity. And I also want to hear your opinion on that too. But let's start with just that description of obesity to you. Besides calories, we have insulin carbohydrate model. We have now the gut is kind of a whole nother topic to consider with obesity, and then toxic exposure, endocrine disrupting chemicals. What do you think of when you think of obesity?
So let's walk this backward. What we're talking about is fat accumulation. And as a human species, we've been successful because we've really been very good at accumulating and storing fat during the good times for its availability through the rough times. So the ability to store fat easily has an enormous survival advantage. Right. No matter what the mammal is, all mammals store fat. And in order to store fat, all mammals do what we call insulin-resistant tolerance. The ability just to make and store fat comes from the consumption of high-carbohydrate foods. And in order to do that, we have to tolerate a degree of insulin resistance to be able to shove that the sugar into our fat cells. Both the liver, when you measure triglycerides are the conversion of sugar to fat, whether that source of that sugar was protein or carbohydrates we ate. Liver produces triglycerides and ships it out to the fat cells for storage. And then both fat and sugar can go directly to the fat cells. We've got a process called DNL, or de novo lipogenesis, which is where the fat cells, under the influence of insulin, can convert sugar to fat. So it is a protective mechanism. And in fact, the ability to convert sugar to fat protects you from the damage of sugar. So the obesogenic genotype, it's a genetically predisposed or genetically controlled factor that relates to insulin production capacity. The amount of insulin you produce, the more insulin you produce, the fatter you get. So, but insulin resistance at a certain time of the year, for example, in the fall, has huge benefits. Squirrels get insulin resistant before they hibernate. That's how they gain that weight. Cows do the same. So all animals have a degree of insulin resistance to accumulate that fat episodically. Now let's go from an era that we've always had as a species, a dominant era of nutritional deficit or food insecurity, populated by occasional abundance. And now let's put ourselves in an era of unprecedented, obscene abundance. Very few people don't live within 50 yards of an abundance of food. All you have to do is walk down the road and there's a fridge, or you drive down the road, there's a McDonald's or a restaurant. There's food availability everywhere. So while food scarcity is still a real problem, for the majority of us, food abundance is the issue. And then it was also driven by industry again that promoted carbohydrates over fat. So we're sitting with this massive amount of carbohydrates that we have ubiquitous access to 24/7, 365 days a year. So now, instead of this being episodic before lean times, it's now every day. The other part that we've got to take into the driving force behind the ability to overeat carbohydrates is the endorphin incentive that they give us. So there's got to be a drive. The drive to procreate is about endorphin incentive. Okay, so there's an endorphin incentive to sex. There's an endorphin incentive to the consumption of carbohydrates. And a number of drugs are based on that endorphin incentive. So now I've got this wonderful feeling that eating carbohydrates gives me in an era of ridiculous perpetual abundance, and I've got the wealth to consume them. So I'm getting high all the time, and slowly over time, I'm developing a relationship with carbohydrates as not a source of nutrition anymore, but as a source of emotional restitution. And I'm leveraging my historical biology to magnify that relationship. As I start to eat more and more carbohydrates, if I'm a high insulin producer genetically, I'm turning that sugar into fat And again, coming back to the old story, there's no ebb and flow. I'm not storing and using. I'm just storing all the time. I'm just shoving in there perpetually. And the diseases we get when we're obesogenic, when we gain weight, are primarily related to the weight itself, weight-bearing joint disease, maybe some sleep apnea, but the predominant diseases we get are not related to the obesity. They're related to perpetually high levels of insulin. That would be Alzheimer's, cancer, autoimmune disease, low testosterone in men, polycystic ovarian syndrome in females. Those are the diseases of elevated insulin levels. If you cannot produce a lot of insulin, you can gain some weight until your insulin resistance gets blocked by the ability to produce insulin. Now you can't shove that sugar into the cells. You can't convert it to fat, so your blood sugar starts to rise. Then you cross over where hyperglycemia, elevated blood sugar, becomes part of the problem. And elevated blood sugar is very pro-inflammatory, causing vascular disease and also disease or vascular inflammation, and also inflammation in the space, the interstitial space between the blood vessels and the cells. What lives there? Your nerves, your ligaments, your tendons, your joint capsules. So now you're caramelizing your ligaments and your tendons and your joints. You're caramelizing your nerves. And you live in Colorado, you know, on a cold winter's day, there's this crystallization of ice on the wires. Yeah. Well, that's how our nerves and our ligaments look. And then they fracture and they break and they get destroyed. So both sides of the equation, obviously a bell curve, where you either gain a lot of weight and have certain disease-related insulin, or the other side, you become diabetic, type 2 diabetic or insulin resistant, hyperglycemic early on. That's the disease spectrum. This group gets cardiovascular disease, stroke risk, inflammatory risks. This group is more related to insulin. So that's what has happened when we've exploited our natural survival biology in an era of unprecedented abundance.
That's so fascinating. The piece that's intrigues me the most because it's an area that I'm probably lesser involved with. I'm focusing on the physiology, and I do talk a lot of mindset. You got to coach these patients and get them stronger, but you really have that behavioral piece down. So when I think of obesity, I'm thinking of the insulin resistance part. It's a lifestyle, but obviously we know that there's that genetic predisposition to becoming insulin resistant and then eventually hyperinsulinemic. But that behavioral component, could you expand on that a little bit? And is that also something that an individual can be potentially genetically susceptible to having that, or is that just completely acquired through environment?
Yeah, good question. So the first thing that we've got to look at is that carbohydrates are not the problem. Our relationship with them is. We demonize carbohydrates. Alcohol is not a problem. It's our relationship with it that is. So we've got to look at our use of the product rather than what the product does for us. Does that make sense? So that's the first. Yeah. That's the first kind of piece of that equation. However, the other mistake that we make is when we know that someone's diabetic or someone's obese, and we say, "Oh, you got to go on a keto diet. We're going to remove carbohydrates." Everything that causes us harm also has an incredibly powerful value. That's why we engage in the relationship with it. So if you remove carbohydrates to solve obesity or to solve diabetes or whatever it may be, you've had a heart attack, now you're leaving this massive deficit in someone's life. And in fact, when you remove carbohydrates, you leave two massive deficits. The ketogenic community, the doctors and the dietitians are very good at, is replacing carbohydrates with other foods at a nutritional level. But when you remove carbohydrates, you're removing pretty much the exclusive emotion management system that those people have. You look in the emotion management toolkit, it's carbohydrates, snacks, and cobwebs. You get rid of the carbohydrates, now you leave them without any real tools to manage stress, to manage anxiety, to manage emotional relief. And one of two things is going to happen. When an unexpected emotionally triggering event happens in our lives, we need relief. So we either go back to carbohydrates or we find something else to do. We get depressed, we begin yelling, and we kick the cat, or we beat our wives, or we start smoking, or we find an alternative. So for me, the crucial thing is addiction management is never about quitting or removal. It's about replacement. We replace the role of carbohydrates nutritionally with real food. We replace the role of carbohydrates as its drug value, as its emotional value, by helping people to diversify where they go to for emotional relief. So if you quit carbohydrates and you start becoming more spiritual, or learn to play the guitar, or join the gym, the role of the gym has very little to do with physical activity and the metabolic rate. Yes, it's benefits, but the primary role of physical activity is up here. But not everybody is an athlete. Not everybody's a thespian. You go to your strengths as they pertain to a healthier emotional off-ramp. And so I think there's a duality of treatment, both in terms of the nutrition, monitoring disease removal, but also the psychology is equally important to sustain this as a long-term behavior. See, if you remove carbohydrates, it's something you're doing to get healthy, but it will fail. If, however, you address the habits, the behaviors, the routines that led you to a particular way of eating, and you change the fundamentals, the foundation of how you live your life, and you are a transformed human being, then it is sustainable for the rest of your life.
Yeah, no, that makes a lot of sense. I'm sure you hear this all the day all the time, I should say, especially now with Carnivore being even more strict. And we're definitely going to talk about Carnivore too, with regards to making just the choice to start a ketogenic diet. A lot of people obviously struggle with that, just making that decision because of how hard it appears to be. I want to ask you, and maybe the answer to this will make it easier for them, because I know your opinion is, I've heard you say it, you got to go all in, like all carbs have to be removed. Can you help the listeners understand the difference between just removing ultra processed carbohydrates, which we all know how bad those are, but leaving in the healthier carbohydrates, your potatoes, your things like that, the sweet potatoes, some fruit, leaving that in, but removing all processed, specifically in the category of the addiction that you're known for helping people address? What's the difference between those two scenarios?
Well, how do you eat an elephant?
You put a lot of effort towards
the way you eat an elephant. Oh my God, it's an elephant. And right. If you look at your relationship with carbohydrates, by the time you have significant disease related to that relationship, it's so enormous. Your relationship is so ubiquitous in your life that if you try to do it all on day one, you're going to crash and burn very badly. The way you eat an elephant is one bite at a time. So the first thing we've got to look at is each person is individual. Not everybody's an addict. Some people are misguided by the current health policy of lots of plants and not red meat. So they're trying to be healthy, but they're doing it in a misguided way because they've been led astray by the incorrect policy suggestions from the U.S. dietary guidelines and the committee. So, that'll transform. Other people like myself are just so deeply addicted that we cannot afford to expose ourselves, to give ourselves permission to those triggers. We've got to look at each person that way. If you got hammered last night, you're not going to drink for a few weeks or maybe a few months. But if you are an alcoholic, you're going to make a pretext as to why it's okay to drink tomorrow. So again, it depends on the individual person. And then we do it. The second part that it depends on is what type of disease you have. If you've got a CAC score of 3,000, you've had 2 stents, and you've got heart disease, you have no threshold. So we have to be more aggressive with that person. If you're a 15-year-old who wants to buff up their body and get ready for the spring, then we can make a slight shift. So it's situational in terms of how we do things. However, it's a progressive thing. A lifestyle change is not a one-time change, and it's not a static thing, and there are no goals. There are only milestones along a journey. And once you embark on this journey, then you keep setting, if you're going to be successful, you keep setting new empowering milestones for yourself. Okay, I ran my first 5K. Maybe I want to do a half marathon. Or I can do 5 sit-ups. Let me see how many push-ups I can do. Or I can play the guitar. Maybe I want to play this instrument. Again, there are so many opportunities that are progressive. And as physicians, it's not an all or none thing. That's a diet mentality. It's a progressive transformation to the extent you can. So some of my patients can't give up their Oreo cookies. It's fine, keep them. But let's start with maybe rice, you don't have that huge affinity for rice. Let's start with the rice, then we work on the potatoes. And it's kind of more of a binary decision per group. And you may end up with getting rid of the Oreo cookies. Same thing with fruit. Fruit is not bad, but our relationship with it sometimes is. Are you somebody who can tolerate berries? Well, if your CGM is doing this on the berries, not a good idea. But if you're fairly flat-lined and you've dropped your weight, I don't have a problem. So the key thing that I think is a problem with internet advice is the best, and this includes mine, the best we can do is be generic. So we give itemized guidelines, but as an individual person, those guidelines may not be applicable to you as a unique individual. So we take information from the internet and we apply it to ourselves. But if we buy into the cult of the internet, and I want to be like Sean Baker, or I want to be like Anthony Chafee, all good friends of mine, I'll never look like them. Okay? I'd like to, but it ain't going to happen realistically. So I've got to stay in my own lane and do what I'm capable of doing to the best of my ability. And as a practitioner, I don't want you to be where I am. I want you to be what's best for you. And I've got to meet you where you are. And all too often, we follow people on the internet who are an N of one. This is what I do. You must do the same. Well, I am not you. And so the answer to your question is really, let's individualize therapy. Let's identify where the issues are and where the strengths are, and let's make progressive changes. Let's eat this elephant one bite at a time, and you'll take the last bite about 10 minutes after you're dead.
No, I love that. And it's, by the way, Doc, it's so funny you mentioned Dr. Sean Baker. I do have a podcast scheduled with him tomorrow, so it's so funny you mentioned that. What a freak of nature he is.
Well, God. Exactly. And but Sean is a brilliant guy. He's done very well for himself, and he's been a brilliant influence on people trying to improve their health.
Yeah.
And the key thing about Sean, even though he says, look, this is my standard, he'll tell you all day long, do what you can. I know Sean very, very well. I was just with him a couple of days ago. We shot a beautiful movie called Animal, produced by a guy called Vinny Lingham, who's one of the sharks from Shark Tank. But
cool.
It's a carnivore movie, and Sean and myself and several of the folks I've talked about are in this movie. It's going to be brilliant. It's going to be released at the Cannes Film Festival later this year, called Animal. And you should ask Sean about it. But he has a dominant role in it, obviously, with Rivero and with the stuff he does. But Sean is one of those people who is a physician, no longer really practicing, but leading a group that is there to help people to transition when they make that choice and give them guidelines as to how to help that. But you don't have to be Sean Baker. You don't have to step in his shoes and live his life in order to be really healthy. And he'll tell you that all day long.
Yeah, it's so. I think with this recent explosion in carnivore awareness, right? That's what we're in the middle of right now. I hear it every day because I have thousands of people that I'm coaching in different capacities, and it's always like, Doc, like, are you serious? Like, that's what you're suggesting? And I'm like, well, it's an option that I appreciate now more so because, quite frankly, to be honest with you, when I first heard about carnivore a couple of years ago, as a weight loss coach having this business, I kind of looked the other way because my immediate thought is people aren't going to do that. People aren't going to stick to it. I think despite how difficult it obviously is, it's the decision people are making because it works, right?
I think we've got to also put it in its place because carnivore is not a long-term, forever way of life for humans. It's a strategy that we use to most radically reduce inflammation and get healthy. It's the ideal therapeutic strategy. But if you overdo it, in my practice, I see a lot of carnivores, and I've always got to be vigilant, including Sean. You can ask Sean about this. But Ben Bickman, a few others have had the same thought process or discovery, is that you can become insulin suppressed, where you swing that pendulum from insulin resistance all the way over to really not producing very much insulin, which has its own issues. And I don't want people to do necessarily what Paul Saladino did, which was...
I was going to say, that happened to Paul.
Right, but you see, for Paul, I had a patient today, a bodybuilder who should be like Paul, Saladino, eating 300-400 grams of carbohydrates, maybe not quite, but that fits him as an individual.
Right.
But unfortunately, I get a lot of patients who've got diabetes who say, well, Paul's eating 300 grams of carbohydrates. I'm going to do the same. I'm going to eat all this fruit. So
I wanted to interrupt the show for a quick minute to let you guys know about the free weight loss guide that I've created. I've taken everything about the Flow protocol and my over 15 years experience working with patients just like you and give you guys a step-by-step guide on how to implement these GLP-1 medications to achieve successful and long-term weight maintenance. So if you see any interest in that, I'll put a link in the description so that you guys can access that free guide. Now, back to the show.
That's where we've got to temper the individualized care. You don't have to be like Saladino. And quite frankly, Saladino went through the eye of the needle 2020 of being fastidiously carnivore to the point that it broke him. Testosterone was going down, electrolytes were off, and he discovered that his insulin was in the toilet. So he uses carbohydrates as a way to trigger insulin, and he can tolerate that high level of carbohydrate. Some people need a little bit, some people need none. It depends on the individual. And it's all about insulin and glucagon, as we spoke about earlier on. So it really has to be individualized care. And as practitioners, we need to understand the biology, not just the knee-jerk endpoint.
I'm so glad you said that, because one of my questions anyways was like, what is your current definition based off of where we're at science-wise and clinical experience-wise? What is the proper human diet? There's so many, Dr. Ken Berry, I've been reaching out to him. Hopefully I can connect with him too as well. And, there's a lot of these carnivore enthusiasts, Dr. Chafee, and I was just actually did a podcast with Dr. Kiltz. I was with him in Florida. To them, so far from what I can see, strict carnivore for the rest of your life. And it's refreshing to hear you say, maybe, is what I'm hearing. Some people, yes, but some people need more carbs, like Paul Saladino being a great example, burning so many carbs. So there's the physical need for carbs because of an athlete like that. But what about the individuals that have to have it or a small amount just for it to be sustainable for them, right? Because they're trying to do the best thing they can. And if you don't give them a little bit, oh, screw it, I'm done. This is just too restrictive.
Right. And so it's situational. A person that is a huge mentor for me is a guy by the name of Tim Noakes. And just in January, Tim and a few other folks published a beautiful paper for endurance athletes. This was published in Cell Physiology just in January. Carbohydrate ingestion eliminates hypoglycemia and improves endurance exercise performance in triathletes adapted to a very low carbohydrate diet and a high carbohydrate isocaloric diet. So they compared people on a high carb diet versus a high fat diet, and they looked at the role of small amounts of carbohydrate for those folks, and they discovered that, wow, you know what? There is an optimization that they can see when they eat those carbohydrates. So to my mind, it really is all about the situation. But the point is that it really, and that's just a brilliant paper Tim and them published just a little bit ago, last month, that discusses the role of carbohydrates in some of these patients. The other person that has done tremendous work in terms of the healthiest people is a woman by the name of Isabella Cooper, who's a PhD student at Oxford. And she looked at a group of carnivore or fat-adapted people that had been so for a minimum of 4 to 20 years.
Oh, wow. And
they all had wonderful blood work on no medication, about as healthy a specimen as you can be, but they were all consuming between 50 and 100 grams, up to 75 to 100 grams of carbohydrates a day, and still in ketosis because they were using the carbs to trigger GLP-1 to manage insulin release, which is crucial in a cyclical way throughout the day. So when you talk about the ideal diet, let's remove the proper human diet, as Ken says, or what does that mean? And I think there are important principles when it comes to the ideal food. And this also in the context of carnivore. So the first thing that we've got to understand is that, I don't know how old you are, but in my lifetime, not a single plant that we buy commercially at a store existed in its current form when I was born. So all the, plants, yeah. Plants have been so heavily hybridized and so heavily commercialized that they've lost their integrity, they've lost their nutritional value. And biologically, as human beings, we do not have the capacity to adequately extract nutrition from plants without supplementation. In fact, what's interesting, tomorrow on purpose, I'm doing an interview with a group from India who are Hindus, who are religiously vegetarian, and they've done a phenomenal job of dealing with metabolic dysfunction, primarily diabetes. And my particular question is, how do you formulate a vegetarian diet that gives you everything because of your religious need to be so? I'm not going to argue with somebody about their religion, but I want to know, how can I help my committed vegetarians to get everything they need from that? And it's going to involve some supplementation. The bang for buck nutrition and biologically, enzymatically, how our gut works is primarily based on animal products. So for me, the vegetables add diversity and latitude and enjoyment to the meal, and maybe a little bit of nutrition, but inadequate to be exclusive without supplementation. The animal products, and ideally a diversity of the muscles of animals, which is the fat and the protein, but then also the other parts of the animal or the whole animal to get your micronutrients. The muscles of animals are inadequate to offer all the micronutrients we need. We need organs, or we need whole animals like eggs or dairy or small fish or mussels or oysters to give us the full nutrient complement. So if you're going to divide the proper human diet that is all-encompassing, the diversity is important. You don't need fiber, but you do need things like salt. You do need those micronutrients as well as the macros. And then we can look at blood work and estimate what the appropriate ratios are. And we have the ability to choose whatever we want, most of us, because of the abundant availability of that food currently. Even though egg prices are high, one less Starbucks coffee and you can buy a dozen eggs.
Yeah, I heard you recently say that don't stress about not getting pasture-raised eggs. And it made me look at my fiance. I'm like, we make such a big deal about that, especially now that we're eating so many more eggs, because I'm 2 months, by the way, carnivore.
Nice. Okay.
And I know we're getting shorter on time. I have to tell you that I was able to stop my testosterone therapy. I was on TRT for 8 years. By the way, I'm only 37.
Okay.
I started TRT really young. My testosterone levels, they weren't super in the tank, but honestly, my clinic was offering the TRT therapy and my levels were a little bit low. I had some energy issues. It helped, and I just kind of stayed on it and didn't look back. But the energy and the brain fog were the big things for me, running a business. So I wanted that push that testosterone gave me. So when I decided to start carnivore 2 months ago, I was like, okay, let's just drop the TRT at the same time. And I was still expecting the typical refractory period that you would expect anybody to go through. I had none of that, Doc. No, I did labs a couple times, so I'm actually going to be doing another set of labs here soon. But when I did, I think it was my second labs, it was 4 weeks post carnivore, post testosterone therapy. I was at 290 total testosterone, still very low, but I felt great. Mm-hmm. I was like, what?
Well, okay, so were you low or did you not need more? And there's a big difference. In other words, right. When, a fine-tuned car doesn't make a lot of noise.
Right.
The car that's going, brum, 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 that may not be a very fine-tuned engine. You may not need that much. So a lot of people have low T, or they have normal T that just happens to be low. You can have an insulin, a very high insulin. If you're not insulin, you're not healthy. If you've got a very low insulin, you may also not be healthy, but it's just got to be in that right range. Let me give you my 2 cents worth on testosterone. I think, first of all, emotively, our society, because of athletes and all that kind of thing, has really demonized testosterone. It's one of the most valuable hormones. I personally don't prescribe it, but that's more an ethical decision because I work in such a wayward place. I don't want to get demonized, but I've got a strong opinion on it. Testosterone, I think, is of great value. Testosterone levels production is affected in males and females by insulin. Insulin is an aromatase inhibitor, and it affects testosterone and estrogen levels. Females tend to have high testosterone, low estrogen, PCOS. Males tend to have low T. So supplementation for a while until you are able to correct the entire hormonal feedback system is absolutely fine by me. The key thing is that you monitor your levels and that you don't overdose, because more is not always better. You monitor your hemoglobin, you monitor your iron, you monitor your PSA as a male. And also, you've got to understand that testosterone is not a sexual hormone. It's been assigned to sexuality because that's one of its jobs. But every cell in every human body has testosterone receptors. It's got a variety of other functions. Primarily, testosterone is one of your storage hormones. They call it anabolic. I prefer the word storage. It's the hormone we use to rebuild and store food during and after a meal. Together with insulin, testosterone, human growth hormone, and T3 thyroid hormone are your 4 storage hormones. So if one's out of whack, then it throws all the others off as well. But if you keep them all at a decent level and you work on reducing insulin, bumping up thyroid iodine, bumping up testosterone a little bit, that's absolutely fine. I think the most important, and again, I'm maverick when I say this, but one of the healthiest, because I get athletes who can get testosterone prescribed, or people with low T, they get testosterone prescribed, but they tend to overdose because it's all they got. I will tell you that just like I said about prostitution being legal, one of the hormones that I think is incredibly underrated and should be as available as testosterone and undemonized, it's been demonized because of professional athleticism, and that's human growth hormone. HGH is one of the most valuable co-hormones together with the other 4. And if you've got a little bit of HGH and a little bit of testosterone supplementation, it is a remarkably good hormone for recovery, for injury repair, for ligament and tendon repair. It's an anti-inflammatory hormone. And you can lower your testosterone dose with a little bit of HRA, human growth hormone. But it's been demonized as being an evil drug. You know, when patients have bad burns, HGH is one of the most useful hormones to accelerate their recovery. So it's an incredibly useful drug, and we've demonized it because of the emotive argument of athleticism. Does that make sense? So I think there's so much more to be said in all the supplementation. At the same point, once you become metabolically healthy and all of those hormones are working well because your insulin resistance is gone, you may not need any of those, especially if your diet is cyclical. So the intermittent fasting, eating for a 6 to 8 hour window, maybe a 4 hour window, and then not eating for a period of time. So you get a rise of the natural hormone and then a fall of those hormones as glucagon goes up. What you've done is you've restored normal hormonal cycling through your carnivore diet. And I bet you are time restricted to a certain extent in your eating. So it's a combination 100%. Of the two. And I think the other problem is we don't spend enough time talking about the pattern of eating. The pattern of eating is as important as what you're eating.
Well, it's funny you say that. So what I've done, and I call it flow, fasting like our ancestors. So my guess is I was primed so that when carnivore was introduced, in addition to my years of so much deep fasting. So flow, fasting like our ancestors has been my strategy, my medical practitioners, and I do the coaching, they do the prescribing. So we get patients into the point where they can do longer rounds of fasting. We get them into like prolonged, extended 36-hour range, maybe even to 48. And we're doing that every single week, not for life, but just for the duration of that initial 3 to 6 months when they're so metabolically dysfunctional. And it really accelerates that fat adaptation and metabolic flexibility process where if they were just doing keto, and I think even just carnivore, I think it would take so much longer. But when you add the long fasting in there, and I've heard you talk about it, you skip dinner every Monday evening. And I was like, oh, this guy, that's what I do. I was like, this is so cool.
But you've also got to understand your biology. I mean, I'm the fat guy. So at a high insulin producer, I'm not going to die of anorexia. Someone like you, I would suggest, again, just eyeballing you, I've got to look at the numbers and everything else, is to rather get in a pattern of an 18-6 or a 24. In other words, a daily routine rather than necessarily the long fasts. The long fasts benefit me because of my biology. So again, individualizing treatment. I've got some people who are slightly underweight, where they've been carnivore, but they're slightly underweight. They do not want to tap into their long-term stores. That's starvation mode, and we can measure that. So it really has to be individualized in terms of the treatment. And the therapeutic arm, absolutely, to get better quickly. Extended fasts, if you can tolerate them, are wonderful. But long term, you've got to decide who you are biologically and what works best for you.
That makes a ton of sense. And I definitely want to finish off back on GLP-1s. And do you have a certain time that you need to be done by?
I'm good. So I'm fine for time.
Oh, okay, great. So we don't have to rush it or anything. So the GLP-1 medications, to me, it is the ticket to making the long fasting easier. It's the ticket to making now carnivore easier too as well. I want to hear how you, because we talked about a little bit about this overview of how you look at them, which aligns with what I do. What is your approach with patients, your clinic's approach? Is every obese person getting on a low dose of GLP-1 first? Most of them, what percentage of patients would you say are starting off with GLP-1s?
Right, I think I take the word obesity out of the equation. What we look at is insulin resistance. You may have cardiovascular disease, you may have diabetes, you may have PCOS, trying to get fertile, trying to get pregnant, you may have infertility related. So there's a variety of indications for it. Now we've got a renal indication for it, and I'm always beyond the renal indication. You can use it for Alzheimer's, but here's the way that GLP-1s work. They're transitional. In other words, first of all, nobody needs a GLP-1. If you're able to conform, you're able to go carnivore, you're able to sustainably change your diet, the GLP-1s are accelerants, but they don't do it for you. So the foundation that I use is, let's get you on a ketogenic type, or I call it a carnivore-based diet. Let's slowly make that transition. And to the extent that you're able to, or if you're very brittle in your disease, if you've just had a heart attack, or if you are a brittle diabetic, and if you're 20 years old and you're healthy and just a little bit fat, we've got all the time in the world, then you're outsourcing to a drug, probably not a good idea. But if you've got major medical issues, or if you're really engaged, but the reality is some people are able to just take something and run with it. Other people struggle more. My permissive patients try really hard, but they trip over their own feet. So if you've tried to quit smoking many times, am I going to deprive you of Chantix the next time you try to quit smoking? Of course not. Okay. At the same time, you got to quit smoking and use Chantix to help you. You're not going to take Chantix and hope you quit smoking. Most people use GLP-1s and don't change their diet. 100%. So they lose weight, but as soon as they come off, or they become resistant to the drug, now they're going on higher doses, now they're experiencing side effects. So the GLP-1s in isolation, that's why the prostitution discussion came in earlier on. When you use them without guidance, you're not changing who you are. You're not changing your relationship with what caused the problem, the obesity or the diabetes. You're just taking a drug to mitigate it. You might as well be on metformin or insulin. The goal here is to begin to transform your diet, get a baseline set of blood work, and then, if you need it, to introduce the GLP-1s for a transitional period of time to accelerate and augment and sustain the hard work that you're doing, climbing this metabolic mountain to get to the other side. Once you're on the other side, we don't stop the medication, but what we do is we slowly withdraw it. You can lengthen the days. You can have it. So some of my premenopausal women will use it in the week of their period because they're vulnerable, and then don't use it for the other 3 weeks. Then you stay sensitive to the medication, and you use it as a weapon where, you don't take Tylenol every day, but when you've got a headache, you take it. So you use it opportunistically like that to sustain a transformation in your lifestyle. And eventually, just like with Chantix, nobody's on Chantix forever. No alcoholic is on antabuse forever. And it's a fault to keep recovering heroin addicts on Suboxone for the rest of their lives. So you use it as a transitional medication while you invest in the behavioral change. That's why I think it shouldn't be by prescription. If people had adequate access to it at a cheap price, and they could engage with you and me to help them with the behavioral change, with that partnership with the drug, we'd see much more success.
Yeah. I agree. 100%. So it sounds like most of the patients are using it short term, or it's a mix. It's a mix. Some long term, some short term.
There's no such thing as long term, because if you use it long term because it hasn't had an effect, you become resistant to it. And eventually you tap out at the high dose. This dose increase is ridiculous, but it's done in lieu of changing your behavior. You don't need the higher dose the super high doses, because you're changing your way of life. But then you look like a darn Shar-Pei dog because you've lost all your muscles. You feel terrible. You've got reflux, your guts. And don't blame the drug for the side effects that come from a bad diet. All the drug is doing is exposing how bad your diet actually is. So if you're eating Oreo cookies and ice cream and lettuce leaves, the drug is going to make you feel terrible because it's exposing the awfulness of that poor diet. If you're on a carnivore-based diet and you've got some intermittent fasting that you're working toward, the drug is seamless. It's in the background. You don't even notice that you're taking it. You're just eating less, you're eating less often. It's augmenting what you're doing behaviorally rather than doing it for you.
Yeah, I think augmenting is a good way to look at it. You look at the data behind the trials they did with these GLP-1s. And I was actually listening to an obesity specialist discuss, he was talking about the concept of, I hear all these people talk about the medication's not working, and he pulls up the charts and the weight loss, and you see there's a lot of weight loss in the beginning, and then, you stall. And he goes, but the medication's still working. No, you have to understand, like, the medication's still working because if you stop the medication, you regain all the way back. And that was his understanding. And I'm sitting there going, okay, how can you not perceive and interpret the narrative behind the way those trials were done? They weren't trying to figure out anything other than how can we keep people on these meds. Yet you have these very intelligent board certified doctors. How are they not able to just take a step back and look like they're so smart, but they're so dumb at the same time?
Well,
I don't get it.
A very close friend of mine is one of the senior diabetic physicians at Eli Lilly. He and I have had lots of debates and arguments about this. Their fastidious belief, their entrenched belief, is that obesity is the problem, that obesity causes diabetes, that obesity obesity is the consequence of insulin resistance in someone who produces a lot of insulin. So when they put you on these drugs, they correlate a reduction in weight with the causative rather than the associative improvement in your health. So they believe that the holy grail is to lose weight, and then all these other problems go away. And yes, transiently, when you address insulin resistance with a medication, your weight goes away as well as the other things. But it's not the weight loss that's causing this. The weight loss is happening simultaneously as your diabetes and as your cardiovascular disease is getting better. What you're doing is you're changing the insulin relationship. You're increasing insulin production and lowering glucagon. I even use GLP-1s in my type 1 diabetics because it's anti-glucagon. And we know that without glucagon, you don't need insulin as a type 1 diabetic. Yes, I said that, and so did Roger Unger, proving that in 2014. It's glucagon that's the problem. So, glucagon and insulin, the relationship, but glucagon is a primary issue. So it's a misguided belief that the holy grail of this management is obesity rather than insulin resistance, and they will not change their mindset. And it's difficult to, because as you lose weight, your diabetes gets better, and it is a direct correlation. But they cannot, because they live in a world of epidemiology rather than physiology. They don't even look at the pathway. What they look at is the correlation between the two outcomes. And that is why epidemiology is the worst thing that ever happened to healthcare in the 1990s when I was in the lab. We become outcome-based, and we confuse association with causality.
Yeah, and I think it's also, I've never actually heard it explained that way, which even strengthens the position that I take, which is just it's a great money making story. It's a beautiful story, and it's difficult to refute without getting really very, very granular like you just did, considering the epidemiology aspect to it.
Well, I think I want to separate the two. Certainly, it's being driven by the money. Okay. But there's also, it is one of those drugs that's incredibly valuable. And you'd be naive to think that the majority of these people working for the pharma industries are purely driven by profit. Some of the executives are, but the scientists aren't. I know these guys, and they're just like physicians. Physicians aren't intentionally trying to hurt their patients, but they're being forced to practice algorithm medicine because of the industry of insurance, because they're employed physicians, and because of the epidemiologic guidelines. So you have to practice according to the guidelines. And these physicians are conflicted between, or the practitioners are conflicted between what I know is best for my patient and what the guidelines recommend, and I don't want to be outside of the guidelines. So we've got to have, and I know, yes, there are the mavericks that are purely after the money. And there's bad actors in everything. But the majority of doctors and the majority of these scientists want the best for their patients. But then there's the money side of it, which has nothing to do with the patient interface. That's the problem. I'll give you an example. Eli Lilly right now has a beautiful drug called Triple G. Retatrutide, and it's one step over Mounjaro. It's gone through clinical trials, very, very effective. Although I disagree, it's a glucagon receptor blocker, where at least a glucagon agonist, where it should be glucagon receptor blocker, but they're doing that to bring up the low blood sugar that is caused by the other two drugs. So they can give you more GLP-1 without dropping your sugar too low, which is weird because, we can go through the science of it, but that's me nerding out.
I do want to jump into that.
Okay. However, Triple G is not being released because it would destroy the money they're making from Zepbound and Mounjaro. So they're holding on to that for economic reasons. But at the same time, I think this is a very important point to make. Nobody, not the most fastidious ketogenic person, if you came in with a blood pressure of 220 over 180, nobody is going to tell you, oh, cut out the carbohydrates and we'll see you in 3 months' time. They are going to put you on 3 or 4 blood pressure medications to get that blood pressure down, and they may or may not talk about carbohydrate diet. Nobody, if you've got an A1C of 11.4 and your blood sugar is 260, nobody's going to say, don't take a medication for diabetes. If you've just had a heart attack, nobody's going to tell you, well, they do, take a statin. So that's a bad example.
Right.
Nobody's going to deny you medication for a serious condition. And yet, one of the criticisms of people that work in our space, and I'm evangelical about our space, why the hell are they demonizing the single most important effective drug that's come along in my lifetime to help people with the disease of insulin resistance? They're demonizing this because they're saying, oh, just go keto, you'll be fine. Well, that may be fine, but I may be dead.
Right.
And
or
so
just go
I think it's
carnivore
just,
now.
that is a problem with the evangelicism of our society and of our ketogenic space that, okay, you may be fine on this. I may not be. I have not used the drug. I've lost 110 pounds. I'm proud of that. But would I use it if I gained 10, 20 pounds? Absolutely I would. Because I never want to be fat again. And I'll take on anybody that says to me, oh, you just don't. Yeah, I don't. My personality is a certain personality, and each person has a different personality. Sean can eat ribeyes all day long. Okay, but and you can tell him I said that, but that is not me. And so I need ancillary help, and my patients are individuals. They are not rats in a cage. Yeah. If I could put my patients as rats in a cage, then we could do the same treatment for all of them. But each patient is an individual that needs to be met where they are.
Yeah, I think that's beautifully stated. Glucagon. Let's talk glucagon now, because not even necessarily in the context of retatrutide yet, just in general, because, we understand basic physiology, what glucagon does, opposite of insulin, the counter to it, raising blood sugar when it gets too low. But can you talk about its context and its importance, both obesity and just weight loss and weight management in general?
So the most important priority for the human body that supersedes everything is energy provision to cells. Without energy provision to cells, you're dead. Okay? So that is and the body will sacrifice everything to provide energy to your cells. It'll steal from your muscles, it'll steal from everywhere to provide energy from your cells. The hormone that regulates energy provision to your cells is glucagon. That's its job. And glucagon will steal energy from anywhere. Insulin regulates glucagon, so the two should work equal and opposite to each other. But when you're insulin resistant, there's a paradox that glucagon is active and insulin is active. So what glucagon does is, and this is again another little bizarre thing, there is no measure of blood sugar. The human body does not have the capacity to measure blood sugar, and yet all diabetics and everybody's putting their fingers and putting CGMs on to measure blood sugar. What the human body has is a direct responsive relationship with intracellular energy provision. And the liver and the fat cells, a large part of their job is to supply energy to the cells and to remove excess energy from the bloodstream and store it. Okay? That all happens under the influence of glucagon. So glucagon has this tremendous sensitivity to cellular energy supply. And it doesn't matter if your blood sugar is 300 or 20. If your cells are short of energy, glucagon is going to use 3 mechanisms to shove energy into the bloodstream to get that to your cells. The first one is it's going to release sugar from the liver. And the liver is always going to have sugar in it. The liver is never completely depleted of sugar. And the liver will make and store sugar independent of insulin. Doesn't need insulin. It needs insulin for other things, but it doesn't need insulin for energy production. The second thing that the liver will do is it'll convert protein to sugar, or protein to ketones. There's some amino acids that are ketogenic amino acids, and some are gluconeogenic, some are both. But that all happens under the influence of glucagon. So it'll steal protein from your muscles or use the protein you've eaten as a priority. So when I hear these athletes eating lean protein, well, it's all just going to sugar. That's a different story, but it'll produce energy, ketones and glucose from protein, and then glucagon will release fat from the fat cells and release those triglycerides, the non-esterified fatty acids, a fuel source to your cells, and also produce ketones. That all happens in response to cellular energy. What insulin does is it facilitates the entry of that sugar to the cells. So at a low basal level, we produce a little bit of insulin, or the diabetic has a pump or a long-acting insulin that they're using to create a small supply of sugar energy to the cells. That's the basal level, okay? When the cells are working, they need an additional squirt of energy, but that requires glucagon to release it into the tissues. Or if you don't have adequate energy in the cells, no matter what your blood sugar is, glucagon is going to release excess into the cells. So what Roger Unger did is he did a beautiful experiment. We reported some beautiful experiments in 2014. There's a YouTube channel that you can look at with these studies reported, where they blocked the glucagon receptor. And in type 1 diabetics, when you block the glucagon receptor, in other words, glucagon is not responding to energy needs. You don't need insulin. You don't need insulin because you're not getting a surge of sugar into the bloodstream.
You're not raising the blood sugar.
You're not raising, and there's enough energy going into those cells that when you block the glucagon receptor, you don't need insulin. And if you think about a ketogenic or a carnivore diet, that in large part is what we're doing when those folks are fasting. That's why in my type 1 diabetics, when we reduce glucagon or we manage glucagon, they don't need very much insulin. And the role of insulin is really, when you give a bolus of insulin, it isn't to get the sugar into the cells. The role of insulin is to block glucagon.
Have they ever researched blocking glucagon as a method for diabetes?
Absolutely, they have.
But it's never came to market.
No, the problem is that there is no drug that we can take long term. And the problem also is that your blood sugars drop too low.
Drops too much.
The obvious drug for insulin resistant would be a GLP-1 receptor agonist, which is the Ozempic, a GIP receptor agonist, which is the Mounjaro, together with a glucagon receptor antagonist to lower your blood sugar and diabetes. The problem is when they did that, the blood sugar dropped too low. So they've actually retatrutide is GIP, it's Mounjaro, which is GIP plus GLP, plus a glucagon agonist to increase glucagon, because these two drugs at high doses cause your blood sugar to drop so far that they now use the glucagon drug, the glucagon agonist, to increase your blood sugar, to prevent hypoglycemia. But you're becoming hypoglycemic because you're eating carbohydrates. So if you don't eat carbohydrates, you actually want a glucagon receptor blocker. I know this is high science, but not a glucagon agonist.
It's fascinating to me. I've been studying retatrutide a lot, and glucagon is that area that's just not talked about as much. And you definitely just taught me a bunch that I never knew about. The biggest thing I had no idea was how glucagon responds to that energy influx that you said earlier. I didn't know that.
Yeah, glucagon is very, very sensitive to intracellular energy supply. And in fact, GLP-1, because GLP-1 gets released in response to sugar in the gut, GLP-1's one job is to block glucagon as well as raising insulin levels. So in my type 1 diabetics who don't produce any insulin, I still use the GLP-1s to block glucagon. Now, what the ADA says, and hopefully the ADA is going to go away or be radically transformed in the next few years, but what the ADA says, there's been 4 studies, maybe 5, I know of 4, where they tested the role of a GLP-1 agonist in type 1 diabetics. And all of them saw a reduction in A1C, a reduction in comorbidities, and a reduction in weight. Tremendous positive effects. But they also saw more frequent episodes of hypoglycemia. And the reason they did is because when they saw a reduction in reduction in blood sugars, they didn't lower their insulin dosing. So they were overdosing on insulin. And the ADA method is keep the insulin dosing static and allow yourself to fluctuate at high levels of blood sugar. So what we do is we use the GLP-1 to bring all those metrics down, but we also lower the insulin. We put them on an insulin sliding scale, and they use less and less and less and less insulin and keep their blood sugars level. And we can reduce insulin requirement by 2/3 over time in our type 1s because they're blocking glucagon. Because most of the insulin is used to deal with the sugar that glucagon's pouring into the cells or to block glucagon. Well, the GLP-1 blocks glucagon. You don't need that insulin boluses to do that.
Wow, that's fascinating.
You know, the other little story is a guy called Ian Lake, and I would urge everybody to look at Ian Lake. Ian Lake is a doctor in the UK, type 1 diabetic, and carnivore. Now, this guy's an ultra-distance athlete. So Ian and his buddy did a really interesting little experiment. It was called a 0-5-100. Okay? And Ian is so skinny, he doesn't cast a shadow. Okay? He's very skinny. He's an ultra-distance athlete. So he runs 100-mile races. So what he did is he said, okay, I'm not going to consume any calories for 5 days. 0 calories for 5 days. 5 days, 0-5. And I'm going to run 20 miles a day, which is basically a marathon a day for 5 days. And when he did that, he was absolutely fine. He was able to produce all the energy he needed, even though he's very lean, to run 20 miles a day. And his insulin requirement went down to almost nothing. And it was an incredibly good experiment. And he was able to do that because he didn't have to block that glucagon surge.
So are you saying that with retatrutide for the obese individual, or maybe not using that term, but the very metabolically dysfunctional, you're saying they would do better with blocking instead of agonizing, right? So not an agonist, but you would want an antagonist, and you think that would produce a better profile.
Absolutely, because you need, that's why I mentioned Ian Lake, because he was able to use very little insulin. Now, this is a guy who doesn't produce any, so all of his insulin had to be given through his pump or through an injection, and he required very, very little insulin. And what we're dealing with obese people is massive high levels of insulin. My highest measured level of insulin when I was fat, and I've dropped 110 pounds, was a fasting insulin of 87, a normal insulin being 3 to 4 below 6. And at 87, I still couldn't completely control my blood sugar. Massive insulin resistance. You inject 20 units of insulin in me right now, I'm dead in 5 minutes of low blood sugar, okay? That's the adaptation. But the point is that if you are not consuming calories or carbohydrates, or you are blocking glucagon, you don't need that much insulin. So it's a massive, rapid correction of insulin resistance. You bring that insulin way down. However, if you're eating a bunch of carbohydrates, now your blood sugar is doing this and you don't have the insulin to shove it in your cells. That's a problem. So the glucagon blocker has to go in conjunction with a no carbohydrate diet. But everybody has to have carbohydrates in their diet, 75 grams for snacks, 100 grams for meals. So again, you're fighting the system. So they created a drug to suit the system that is a flawed system in the first place.
Yeah, rather than the necessary thing it should be doing. Do you think the addition of it, the way it is, that stimulating additional glucagon release, that impact of having increased lipolysis and breaking down and production of ketone bodies, right? You should have an increased, faster ability to get into ketone body production. Should that yield, at least compared to maybe tirzepatide or semaglutide that don't have that additional receptor stimulation, should that produce better muscle preservation because you're able to slip into ketosis faster?
Great question. It should do, but you're still getting the energy demand. You see, the biggest problem with muscle wasting is that people aren't eating. So they're at a tremendous caloric deficit because they're hardly eating. And as I said earlier, they've got to get their calories from somewhere. And if they're living on their own stores, the body has to break those energy stores down. Now, if you are running at a high level of insulin, the most dominant thing that insulin does is it switches off lipolysis, switches off the breakdown of sugar of fat from your fat cells. So even though you're fat, you can't use your own fat. Well, where do you get energy from? You break your own muscles down, especially if you're a bump on a log. Being physically active and eating protein on these medications is the best way to preserve your muscle mass.
Key.
Yeah.
Gotcha.
So these people are still eating carbohydrates. They're still triggering insulin release. Despite the GLP-1s are augmenting, GLP-1 releases more insulin, blocking fat utilization. Where do you get your energy from? Your muscles. So in my practice, we put these patients on a high carnivore-based diet by fraction. So when they do eat, they're eating fat and protein, which lowers that insulin level despite the GLP-1 triggering insulin, and blocks the glucagon so that they're able to preserve their own muscle.
So literally, this isn't a fear-mongering statement. It's off the mechanisms, and you obviously understand this stuff very well. When we're saying that if you're going to do them wrong and without the proper intake of protein and resistance training, you're going to make yourself worse. Then, like, it's one thing to say you're not doing it right, but we're saying mechanistically wise, you're going to be worse than if the scenario of having enough protein and doing resistance training, which I think people just have no clue, right? About that.
I think you improve transiently, but long term you get worse. You can go on a vegan diet from the standard American diet and do great for a while, but then the deficits start running in. So the challenge there is everybody sees the early benefit. Because remember, when you're eating in abundance, you're eating not only the bad stuff, but you're also eating the good stuff. So you've got this massive store of everything. And when you start to tap into that store of everything, you always get better first, and then you get sicker.
Right.
Does that make sense?
Yeah, 100%. And I think I'm ready to call it a wrap right there. That was amazing, Doc. And I appreciate that. Where can people find you? I have patients that I definitely want to be referring to you. So I'm so happy that I got this chance to do this podcast so they can see it. I know that did I hear that you're working with Ken Berry's wife?
No, I'm not working with Nisha. I know Nisha very well, but I'm not working with her. No, they've got a whole group that they've started up, but I'm kind of on my own, in my own practice. I'm happy to take rookies trying to do a ketogenic diet. We're happy with that. I've got a wonderful dietitian that helps us, but and again, I nerded out with some of the science that we spoke about here, but my focus is on the people that are doing really well or maybe had that heart attack or whatever it is, helping them to navigate through what they're already doing rather than start from the beginning. So I run a clinical practice. I'm a clinical doctor in the trenches seeing patients. I see patients from all over the world. So we do Zoom, we do WhatsApp. That's the beauty about the practice is the majority of my patients are seen online like we're doing right now. 561-517-0642 is a number you can call, WhatsApp, or text, and we can set up that visit. So I'm in clinical practice. We review blood work. We opine on certain transformations you make based on blood work. So it's a reactive, not just a knee-jerk. We react to where you currently are. And then also the general information is out on our YouTube channel. I'm on YouTube, Facebook, TikTok, but YouTube is Carb Addiction Doc. And we have very much a substance abuse practice rather than a nutrition practice.
No, that's amazing. I have a lot of international people that I'm going to be sending your way because, we're primarily set up. International people can from outside of US, right? Can join my coaching programs.
I mean, that's the beauty for me about, you asked me what drives me is I had somebody in Germany, I had someone in Croatia, I had somebody in Japan today. That's just my smorgasbord of patients that it's a world community. And that's the beauty about it.
And you don't have any trouble ordering them labs wherever they're at?
No, we work through their local physicians. The US is archaic in terms of how we've arranged our healthcare system. And the gatekeepers are physicians and practices, and you've got to overcome their beliefs before you can get your own health taken care of. Whereas not everywhere, but most countries, okay, I'd like to get these labs done, and the healthcare system is such that it supports, even though they don't know exactly what a glucagon level does, they're going to support that information. Or you travel to places where you can get your healthcare done very, very inexpensively. I'm South African. I go back to South Africa to get my dental work done. And
really,
of course, it pays for my trip plus the dental work. Whereas here, I would, that wouldn't even cover my copay. So medical tourism is something that we deal with quite a bit, but our international patients actually get taken care of very, very well. And there's certain places that we send certain people for different testings.
Yeah, no, that's amazing. And I'm definitely looking forward to having that referral source. I was just going to say, do you see a biodentist?
I do not see a biodentist. I just got a regular guy that does three of us in the family had teeth cleaning and I had a crown placed, and it cost me $200.
Yeah.
All three, okay? In this country, you don't walk through the door for that. So, my dental care is minimal rather than maximal, if you know what I mean.
Oh, totally. I was just curious because, the whole root canal and biodentist avoids the root canal, toxic tooth. Fascinating. That book that I read, I had no idea. There's people that I've literally talked to now that it's like, that was my source of toxic exposure was the freaking root canal.
Oh, there's no question that the way we did that, a mouthful of mercury or whatever, it's awful, and you can replace some of that stuff. I played rugby for a large part of my life. I broke 7 teeth. And so those are the boys that are steadily, I hang on to them as long as they can, and then they have to be helped and fixed out. It's when you're sitting there with your tooth in your hand that, okay, the time has come to put something in its place.
It's been awesome, Doc. I'm going to go ahead and end it here. And I look forward to maybe doing another one with you soon.
Great. I appreciate it. Thank you very much.